webinar features the Housing Affordability Breakthrough Challenge winner, Gulf Coast Housing Partnership, and their winning breakthrough idea, health and housing. My name is Christy Smith, and I have the privilege of leading the Housing Affordability Breakthrough Challenge for Enterprise Community Partners in close partnership with Wells Fargo. On behalf of both organizations, we thank you for being part of today's dialogue as we hear from local, state, and national leaders. This esteemed panel will discuss the challenge of identifying resources to construct affordable housing and the innovative approach Gulf Coast Housing Partnership is using in a new financing structure where managed care organizations are partnering to create both affordable housing and accessible, effective healthcare. The Housing Affordability Breakthrough Challenge was created to identify and accelerate ideas that could transform how affordable homes are built, financed, and provide a gateway to resident stability and success. This is the 6th of our 6-part webinar series to not only highlight each of the 6 challenge winners, but also create space for leading voices and a diversity of perspectives on a variety of issues that underscore how supporting transformational ideas and innovations is imperative to developing new housing affordability solutions. I encourage you to visit housingbreakthrough.org, where you can find webinar recordings from this entire series that have focused on justice-involved housing, affordable homeownership in rural and tribal communities, a new equitable underwriting system, designing trauma-resilient communities, and a forest-to-home model propelled through cross-laminated timber, responsible forestry, and community-driven design. Be sure to just subscribe to Housing Breakthrough News to learn more about the progress of our 6 winning breakthrough ideas, including Gulf Coast Housing Partnership, and stay informed about future events. Before I introduce our moderator, I'll ask Connie Wright, Senior Vice President and Housing Affordability Philanthropy with Wells Fargo, to join me in welcoming our audience and panel participants. Connie led in the design of the Housing Affordability Breakthrough Challenge, and her leadership continues to be instrumental as Enterprise and Wells Fargo are supporting these transformative new solutions. Connie.
Christy, thank you so much for that introduction. I'm really thrilled to be on the call today. Looking forward to the dialogue. I am Connie Wright. I am part of the housing affordability team for the Wells Fargo Foundation. And as Christy said, I have collaborated with her from the very beginning relative to the Breakthrough Challenge. And honestly, it has been all that we'd hoped it would be. It's been a great ride for us to go through this webinar series where we are highlighting and featuring all of the Breakthrough Challenge winners. And certainly Gulf Coast Housing Partnership is the last of the group, but we are certainly just as thrilled to be able to engage in this dialogue today. The work that we have done for the Foundation for Housing Affordability, we have tracked housing and health over the last couple of years, and it has evolved over time. But there's still much to do. The gap still remains between health and housing. And so when we saw that Gulf Coast Housing Partnership was one of the 6 winners, we were thrilled because it was really a very innovative, of course, innovative initiative, but it also really did put more meat on the bones and framing and progress around closing the gap. And so we will look to track this initiative closely. It will help to inform the work that we will be doing as we move into 2022 and really look to help us in leading the way around this aspect of housing affordability. So with that, I would like to finally just thank you all for joining today, and looking forward to your engagement and the dialogue. So with that, I'll turn it back over to Christy.
Great, thanks so much, Connie. Following today's panel discussion, we will have time for Q&A, and we encourage you to submit your questions in the Q&A feature of Zoom. We'll get to as many questions as possible in the last 10 or 15 minutes of our time together today. And if you are engaged in this conversation through social media, please use the hashtag Housing Breakthrough in your posts. So let's get started. I'll now turn it over to today's moderator, Mary Elizabeth Evans, who is a project manager with Gulf Coast Housing Partnership. Mary Elizabeth, thank you so much for moderating and participating in today's discussion. I'll ask that you now introduce yourself as well as our panelists. Take it away.
Thank you. It's a privilege to be here today. As Christy mentioned, I'm a project manager with Gulf Coast Housing Partnership. I've been with GCHP for a couple of years, and prior to being here, I spent 10 years at a community development financial institution, Hope Credit Union, and have experience before that working at a couple of community-based organizations focused on neighborhood investment and revitalization. Gulf Coast Housing Partnership, we're a nonprofit developer. We focus in the Gulf states of Mississippi, Louisiana, Alabama, and Texas. Our region here in the South is a very high need region with high levels of poverty. Alabama, Louisiana, and Mississippi rank in the bottom 5 in the nation in median income and the last in health outcomes. These states need 220,000 additional affordable homes to meet demand just for extremely low income families. Despite these challenges that our communities face through strong partnerships and through robust real estate finance capacity, GCHP has been able to deliver more than 3,200 affordable homes and nearly 400,000 square feet of community service facilities since we were founded in 2006 after Hurricane Katrina. We work primarily in low-income communities with a high concentration of non-white residents. We choose our partners because they represent and are from the communities where we work, and this adds really significant strength to what we do. So I'm very pleased to be here today with some of our partners on a project that is one of our first of our health and housing initiative. These are partners in the Pearl Senior Living Community, which is a historic rehabilitation of an old Holiday Inn in Jackson, Mississippi, which is actually also my home. We're going to be providing 76 units of primarily senior housing, and there'll be a federally qualified health center, Jackson Hines Comprehensive Health Center, that will be located on this site. This is a project that has taken that's years in the making, and so I'm excited to introduce our panelists today that are going to help us talk about our innovative health and housing approach and the Pearl as an example. Primus Wheeler is here with us today. He's the executive director of the Jackson Medical Mall Foundation. The Medical Mall Foundation manages the Jackson Medical Mall facility, which is a former shopping mall that was turned into a one-of-a-kind comprehensive healthcare facility providing human, cultural, healthcare services to more than 200,000 clients per year, as well as a range of economic and community development initiatives. Primus graduated from Tougaloo College, which is in Jackson, with a BS in biology. He has an associate degree in respiratory therapy from Hines Community College and a master's degree in education and administration from Jackson State University. Senator John Horn is with us today. He's a 29-year veteran of the Mississippi Senate, and he's currently chairman of the Senate Labor Committee. He has significant expertise and experience in economic and community development, including time at the Mississippi Development Authority, which is the state's economic development agency. Outside of the Senate, he's a business consultant that specializes in affordable housing, healthcare, and information technology. He's a graduate and former member of the Board of Trustees at Centre College in Kentucky, and he's completed work at Jackson State University Community Leadership Development Institute and the Governor's Center at Duke University. Next, we have David Kulik. He's a founder and managing director of the Focus Group, a management consulting firm focused on public health commercialization. David concentrates his work on research and strategy to inform advanced health delivery models, social determinants of health, and population health and public health innovation. He's worked on growth strategies and organizational sustainability for 15 years across all 50 states, as well as 15 countries. He earned his master's in public health from Tulane University, and he has a bachelor's in chemistry from the University of Buffalo. Kevin Cresci joined GCHP in 2015. He's our Chief Capitalization Officer at GCHP. He oversees the organization level grant funding, new markets tax credit allocations, as well as concessionary lending activity through GCHP's $30 million community loan fund. Prior to working at GCHP, Kevin served as the Deputy Director and Interim Executive Director for 9 years with Project Homecoming, which is a nonprofit rebuilding agency born out of post-Hurricane Katrina rebuilding efforts in New Orleans. He has a BS in computer science from Marquette University, a graduate certificate in construction management from University of Washington, and an MBA and a master's in finance from Tulane. So I'm overwhelmed with the qualifications and prestige of all of our panelists today, and really excited to jump into a conversation about health and housing. As I mentioned previously, the states that we work in have extremely challenging health outcomes. Mississippi ranks 50th overall in the country in health outcomes, and 48th for having the most preventable hospitalizations. In Jackson, Mississippi, which is the focus area that we're going to be talking about today, 23% of the city's population live in poverty. So we're really dealing with some complex issues that our health and housing approach, and that the Pearl is really working to address. So GCHP's model to really work to address these challenges has multiple layers of innovation, since that's what we're focused on today, including culturally competent preventive care, accessible on-site clinical care, integrated technology and data sharing, and innovative financing by using healthcare payers like Medicaid managed care organizations as key partners. I do want to mention, as we're talking about the importance of partners, I introduced our esteemed panelists, and want to mention a few other key partners that are not with us today, but that are absolutely critical to this model and to the Pearl in Jackson. Jackson Hines Comprehensive Health Center is the largest federally qualified health center in central Mississippi that will be located on site at the Pearl Senior Living Community. Our development partner that's not with us here today is Pearl Street Community Development Corporation. Pearl Street CDC is a nonprofit community-based organization that was started by Pearl Street AME Church, which is a key leader in community development in the city of Jackson, and has a long history of serving the city and community members. So welcome to all of our panelists. Without any more delay, we'll jump into our conversation today. So we want to start with a question just to frame why we're here and what's so important. So we want to start really talking about what is health and housing. And Primus, I wanted to start with you. What does the term accessible healthcare mean to you?
It means a lot of things, and thanks to Mary Elizabeth for introducing me and having me on this panel today. But accessibility to healthcare simply means timely access to health services that best promote greater health outcomes. And there are a lot of things that are actually involved in that process, but the main one is availability. And you got to make sure you have that healthcare services available. The next one is affordability and transportation. One of the things we find here at our place is that most folks miss their appointments because they don't have adequate transportation. You got to have a safe and accessible place and space for them to actually come to get the services. And then I guess the part that really causes most hiccups with low-income patients is that communication gap between the patient and the provider. So it's very important to be able to close that communication gap and to close that trust gap between those individuals. So sometimes a third party is going to have to be involved in that communication process to make sure that we have adequate communication. So there are a lot of things that are involved in why people don't get good health care or why they do get good health care. But at the end of the day, all you're trying to do is improve health outcomes.
David, can I ask you to pipe in on this conversation about accessible healthcare, and also if you can add how housing is a social determinant of health through your work?
Absolutely. First off, I want to say great to be here. Really excited for this. And this has been a long project through partnership. And I think it really, as we get through this conversation, I want to highlight it multiple times how important the collaboration is to be able to identify roads and paths towards success. But in answer to your question, health and housing is a concept that is both new and old, right? It means not necessarily just creating a referral point from point A to point B, but really integrating these two things together and thinking about housing as a social determinant of health and thinking about integrating care management, social support, direct clinical services directly where people live. Increasingly, this involves digital services, connected health, and all of those other assets to be able to wrap around an individual in their natural environment. And this gets to this, the question of what does it really mean to have accessible healthcare, which is a great question because it's not about the provider, it's about the beneficiary. And so it's about understanding the services that they need, when and where they need it, but also in an equitable way. There is inherent bias in how certain individuals are able to access services based on income, based on socioeconomics, based on race, based on ethnicity. And so accessible healthcare is really thinking about how you overcome all of those together, and health and housing can really do that in a comprehensive way, in a way that ultimately gets to better health outcomes. And then in answer to your question, what does it mean when you talk about housing as a social determinant? I just want to frame this back. I know social determinants of health are, widely discussed. Just want to, for level setting purposes, right? Social determinants of health are the 60 to 80% of health outcomes that are not driven by direct healthcare services, right? So these are non-clinical services that you don't get in a hospital or at your doctor's office, but ultimately contribute to your mortality, your morbidity. And these are things like housing, food, transportation, community care, social services. Increasingly, there's an awareness that social isolation is an important as a social determinant. But particularly around housing, it was always viewed as relatively tangential to healthcare. And it's only recently that we're incorporating housing and healthcare into the same dialogue. And that's where we come to health and housing as a concept that now health insurers and hospitals are recognizing are core to their outcomes. And it's huge, not because the research is any different or we have new information, but by understanding this together, now there are new opportunities for partnerships and can unlock ultimately data and unlock capital in new ways.
Yeah, thanks, David. Kevin, can you talk a little bit about what health and housing means to GCHP and how the Pearl senior living community in particular is an example of how GCHP is thinking about health and housing?
Sure, happy to. Again, thanks. Like everybody said, really thrilled to be here and to be here in this moment where we're about to close on our 2 pilot transactions for the Health and Housing Initiative. Like David said, it's been a long time coming and it hasn't always been easy. For us as a developer, yes, Senator Horn's laughing because he's been there too with us throughout. So as a developer, some of the stats that Mary Elizabeth had pointed to and Primus, further talked about are clear that health outcomes in our region are challenging and scary in a lot of ways. And we know as a developer that the capital stack to create affordable housing is not easy, especially in our region where we have some of the lowest incomes in the country and our construction costs are still high relative to that. So gaps are big. So it's very clear that healthcare outcomes can be impacted by housing. What wasn't clear was how we fill that gap more so that we can create more housing. And so when we, originally talked to Primus and a lot of the folks in Jackson, it sounded great that we could do a lot of this, there could be these impacts, but the question was, how do we're having trouble creating affordable housing as it is. And so we eventually got to health and housing being two things for us. One is, how do we impact residents and improve their health outcomes? And so that's some of the things that David had talked about and Primus had talked about. But then also for us as a developer, how do we bring capital that is lower than market to those developments to leverage other sources of capital to make them happen? And so for us, that's a really key piece, is we got to Medicaid managed care organizations who cover a lot of the folks that live in the housing units that we create as a source. And so we've been in lots of conversations to understand what the pain points are for those organizations. And the critical piece, Connie had sort of alluded to in terms of what makes our approach different, is that we want to approach this in a scalable way that makes sense for the healthcare payers as much as it makes sense for us and for the clients. And so that doesn't necessarily mean that large health insurance companies write us a $20 million check so we can build as much housing as we want to, because they're not going to be able to keep doing that. But if we can find that nexus where there's health impact that they can factor into their evaluation of the return on their investment, the scalability is possible. And so really sort of in that respect, these healthcare companies are some of the biggest companies in the world, and they have to have a return on their investment. We want to factor the improvement in health outcomes and reduce costs as a result of that as a part of their calculation of that return.
Senator Horn, I would love to turn it to you to talk about your view on health and housing. And you've been really key to one of our first pilot projects, the Pearl in Jackson, moving along over several years. It's a pretty complex project with a whole range of financing sources. Can you just talk a little bit about this project and this initiative?
Yeah, well, thank you, Mary Elizabeth. And before I start, I want to give a shout out to Wells Fargo and to Enterprise Community Partners for their support and involvement in this initiative. We couldn't have done it without the likes of you guys. I think about this process. I have to think about when I first met Kevin Kretschy. He was almost clean shaven with a baby face. And now he's got a full beard, and he's a mature looking young man. That's how long we've been working on this project. And I
had no children when John and I first met, and I have 3 now.
Exactly. But I wanted to just go back to what I think Dr. Aaron Shirley called culturally competent care. Dr. Shirley was the founder of the Medical Mall, and he's a recipient of a MacArthur Genius Award, but was a real mover and shaker when it comes to providing healthcare to those most in need in Mississippi. And I think in that context, he wanted to get healthcare to the lowest common denominator as quickly as possible, which means that we need to make it accessible, we need to make it affordable, and we need to make it, again, culturally competent. Mr. Wheeler can talk a whole lot more about that than I, but I think we cannot overemphasize the importance of the philosophy of Aaron Shirley as we have moved forward with this project. The primary healthcare system is critical to many people who are in the lower income strata. And so you can't overemphasize the accessibility of primary care to people who are in need, especially in a place like Mississippi that's got all the health indicators and comorbidity issues that we see our state experiencing. So I really believe that once a person can focus beyond being in survival mode, you can reduce their stress, you can get them closer to healthcare, and will improve their health outcomes tremendously.
So I think we've made very clear how key partnerships are to this initiative and to what we're talking about today. Senator Horn, can you talk about your view on partnerships with our health and housing approach and with the Pearl specifically? I mean, each of you all on the call today has a different role in health and housing. And so Senator Horn, I'd like to start with you to talk about your view on how partnerships have contributed to where we are and close to being able to launch our first project in Mississippi.
Well, let me say that I have seen very few partnerships with as many moving parts as this project has. We've involved the private sector, the banking industry, the equity providing elements within our community, state and local government. We've had to involve the Division of Medicaid, managed care providers in the state, Mississippi Home Corporation, the City of Jackson, CDBG administrators who run the Community Development Block Grant Program, the Regional Housing Authority. So it's a heck of a partnership. And I think when you're trying to forge partnerships like that, it's important to know what makes people tick. What the needs of a managed care entity are maybe different from what an elected official is looking at. It's different from what a housing authority is looking at, from what a home corporation or a bank might be looking at. So you have to know what makes them tick. And you also need someone who has the ability, you need someone who has the ability to convene people in fairly short order. Sometimes it needs to be somebody that folks have a hard time saying no to on taking a meeting. And you have to be able to communicate the big picture using an elevator speech, because folks will easily blow you off. I think the main thing is you have to demonstrate to administrators, policy wonks, bureaucrats, how their participation will make them a hero. Everybody's looking to be a hero, and they want to look good, and they're risk avoiding. So you have to give them that elevator speech initially to give them a sense of how they can become a hero if they participate in something as innovative as this, and that they will be successful in reaching their goals and objectives. You have to navigate communicating with and how to bring potential partners together who might have competing interests. So it's a delicate balance, but the end result is a beautiful thing. And I think that's what we're seeing with this particular project.
Absolutely. Primus, can you talk about why partnerships are so important in this project and what you feel like is most important from your perspective about those partnerships?
Promise, you're on mute.
Gotcha. Thank you. I'll be happy to. I think relationships, we had to start from the relationship standpoint with this project. I met the folks at the Pearl when they're actually a faith-based organization, but they have very little faith because they've been burned a couple of times by other developers, folks who had a lot of ideas that they wanted to get this project done, but didn't have the wherewithal to get it done. So we started Erica Reed and I went over and just had a conversation with them and did not promise them anything. We just started talking about, what do you want? Where you want to go with this, and how long you've been at it? I think they'd owned the property probably 10, 12 years and have struck out a lot of times on deals and had no faith that anybody was going to ever do anything with it. I think most of the membership of the church were mad with the folks at the CDC, and the CDC folks mad with the folks at the church, and folks in the community mad at them, and because a lot of promises have been broken. And so we had to build the relationships with the community between the CDC, the church, and the community. That's the first partnership that we put together to get everybody back to believing that everybody was there for the right reason and that nobody was trying to get credit, nobody was trying to do anything, and start to build those relationships at the very beginning of the program. And we put together a strategic plan early in the process and involved the whole community. Folks came out, filled the church up, and I was surprised that folks from the community came in to hear about what was going on and how to get involved and to get information. Because when you don't give folks good information, they make it up, and most time they make it up and they use stuff adversely against you. So that was the way we got it started. And because we've been burned a couple of times at the medical mall also, I know who not to bring to the table. So once we started the process, got the strategic plan finished, got the community, everybody back on the same page, I said, this has got to be slow walked, it's got to be worked properly. So the first person I called was Senator Horn, because he knows everybody, knows everything, and I know that he will do what he says he's going to do. And so he confirmed with me, and I've known Kevin and Kathy for a while at Gulf Coast, and we've been talking about other projects. And so he and I had a conversation about inviting them to town. So they came to town, and basically we were finished kind of with our small portion of the partnership, because I wanted to connect them with the church, with some folks who could actually get this done. And so the main partnership with us was developing the relationships with the community, so that the folks won't be at the city council meeting complaining about they didn't know what was going on, and this was going to be something that would be adverse to the community.
Well, and just to add for context of all of our viewers, the Pearl, as well as H3C, GCHP has 2 health and housing projects. The Pearl in Jackson is on Highway 80, a corridor that has been a target for the city of revitalization for a long time. And Primus, as you're talking about, Pearl Streets being discouraged in the early days, there are many people that I've heard say that's not possible. It's not possible to renovate that old hotel. The city just needs to tear it down. So it's a challenging, it's a vision that I think all of the partners collectively have together. And that collective vision and all the strengths of the partners are what's really pushing us forward. David, can you talk about, from your perspective, what is this partnership about, and how do you think success will be defined?
Yeah, for sure. I think echoing on the points that were just discussed around the need for community partnership and the need for state partnership, I think then the added element onto it is the healthcare angle. Right. So without community partnership and without the state buy-in, it doesn't happen. But I think then the next question is, how do you then translate that into a viable partnership with non-traditional entities? Right. And, healthcare entities are in this space of housing relatively new. There are organizations that have been working in this, healthcare organizations that have been working in this for the last 10 years. But it's not widespread. And so success is around being able to describe the value in the story and the narrative from a resident perspective. I think, we've talked on this, and I just want to go back to a point from the beginning. We had talked around health impacts and health and as it relates to housing, but I wanted to highlight a couple of key pieces of data. I mean, there's many, but there have been a couple of studies, one in which it was done in Oregon, where among 10,000 people, where they had unstable housing, when you provided stable long-term housing, you decreased Medicaid expenditures, healthcare expenditures by 12%, which is huge. And then a variety of other studies have pointed to providing housing generates offsets of about $29,000 in healthcare spending per year, even when you account for the housing costs, right? Which exceeds the amount that most people actually spend in a year, right? Which is just an average across, which means that there is this net value created by housing for people who have housing instability, for people who have challenges on tenancy, for people who have risks on foreclosure, for people who have issues on both on short-term access to housing as well and transitional housing. And so there is a healthcare value consideration in here. And so from a partnership perspective, it has been about communicating that and getting the state Medicaid office and the managed care plans on board to this project, and realizing that this is not just a traditional effort in terms of economic development and community partnership. Not to undermine the importance of those, but it becomes even more than that. And success involves having the healthcare entities recognize that this is a shared burden that they have, not from a community impact perspective, but purely from their bottom line as well. Right. And so housing is a human right. It is also a driver of healthcare spending. So I wanted to connect it back so that there's this recognition from a partnership side that it drives mission and it drives margin. And, aligning on those two things has facilitated a fruitful partnership nationally in this dialogue among organizations that have made really strong commitments to housing. And I think particularly so in Mississippi. We talked at the beginning about some of the challenges and health outcomes in the state of Mississippi and where it ranks. And I look at this as essentially flipping that around, right? This is one of the most progressive models that I see in working nationally in terms of integrating health and housing. And so I look at it as leading the nation in this, right? And its approach towards kind of thinking about full integration on community partnerships, really creative financing, buy-in from the top levels of the state and horizontally across health systems really does present a very different approach towards health and housing. And just for a second, health and housing across the country has been well documented and well explored. But what I do want to call out that is so fundamentally different here is how there are so many entities involved in this, from community-based, faith-based, state-based, and private healthcare delivery systems. All have come together to recognize the shared value.
Yes, it's really exciting partnership. Kevin, can you talk about, really what is the innovation we're talking about here? I'd love to sort of hear from you, sort of an overview of really what's innovative about what we're doing. And then David, maybe hear from you as well about why and what's so different that you've just started talking about. But Kevin.
Sure. Yeah. So there's, I think the innovation is on several levels. And what I want to really reiterate is we're not, our idea that health and housing are interlinked and can have positive impact is certainly not our idea. What we've done is take pieces of ideas from folks who have done a lot of work all over the country, seen what's worked, seen what hasn't worked, or seen what needs to be improved upon, and then try to leverage that into something that's scalable. Our approach has always been, okay, it would be great if we can do a one-off project, but scalability is the key. And so the innovation on the health and intervention side, Primus and David have described, where there's a core component being culturally competent care and accessible care. In terms of the housing, we're also focusing on building, that's something, competent care, accessible care, clearly that's important for health outcomes. On the housing side, we've also looked at what makes a healthy building. And so we've looked into different certifications and approaches and design. And that's something that, again, contributes to some of those outcomes. But one of the big pieces that we've been working on, or at least that I've been working on for our piece of it, is how do you get a healthcare payer to the table? When you sit down in a room with a bunch of people and say, well, of course we're gonna save money for healthcare payers, so they should clearly want to invest. Simple as that. Let's go talk to them and get some checks. And it's clearly not that easy. We had, for those of you who who have dealt with healthcare payers or systems in the past, a quote that I hear a lot is, if you know one healthcare payer, you know one healthcare payer. And that's true in what we've found, but there are some kind of unifying motivations. And what we had to do initially was just to talk to as many people as we could. And Senator Horn was a great resource for that in terms of making those connections and opening doors for us and learning what healthcare payers were the best to work with in a certain region. We had talked to one healthcare payer at the state level and loved the concept, but would have needed buy-in from a national corporate level. And at the moment, the president at the state level knew that payer was not putting a focus on social determinants of health as much as others were. So that while he would love to support it at a state level, the kind of resources we would need to make something like that happen was really going to be on a corporate level. So maybe we come back in a couple of years to that particular payer. When we had conversations with other payers, we learned that they might have an interest in providing low-cost debt, but that state contracts play a big role. And so that's one of the biggest pieces that we've learned, is that state Medicaid contracts are a big motivator for healthcare payers, for Medicaid MCOs. And so we can kind of use that as leverage, where an MCO might be able to be more competitive for a state contract. But the negative side is that some of the folks that we talked to were less inclined to provide some of the longer term debt that would be necessary to align with low-income housing tax credit compliance periods. And that was going to be an issue. So we could maybe get debt for 6 or 7 years, but we couldn't get it for 15 years. And so we had to first figure out what the motivations and problems were for the healthcare payers, and then try to come up with solutions that would address those. And so in some of the financing structure that we've created, we've addressed some of those, and we continue to learn as we talk to different payers. So it's been a long journey, and we've had to knock on a lot of doors and have a lot of conversations to understand what some of those takeaways are and where the motivations are for those healthcare payers. Our goal in terms of scalability is that we can get these first pilot projects done from the promise of the impact that they'll have, or the motivation that it will make an MCO more competitive for a state contract. But then in the long term, the scalability will come, as David had mentioned, in tracking that impact. And I saw a question in the chat come up in tracking impact, and that's something that we've come a long way on, and we're really looking forward to in this next stage as we start to build. And that's the relationship that we have with, for example, in Jackson, with Jackson Hines Comprehensive Health Center, and with United Healthcare, the provider of the debt there, and that sort of interrelated data and impact. One of the things that was sort of funny when we started that data collection process and talking through how we're going to do this, we sat down with United Healthcare and Jackson Hines Comprehensive Health Center, and we said, okay, it would be great, United Healthcare, if you can share this data with us or with Jackson Hines so that we can continue to track that impact. And their response on a lot of things was, we're already sharing this data with Jackson Hines, that it's already there, that they have it. It's just a matter of coordinating, selecting, and finding out how we can track and impact that. So one of the ways that we've solved that problem is lots of conversations. And I wouldn't say that we've necessarily solved the problem, but we've come a long way, and we will learn as we continue to explore these pilot projects.
I'll just add, in terms of, you're talking about multiple levels of innovation here, which is certainly the case here. As the project manager for the Pearl, I see very well the benefit of this low-cost debt. This project likely would not be moving forward without the low-cost debt that United Healthcare is providing. So just to highlight that for everyone, this is a key feature of our financing stack, and I think an important resource for us to look to scale. So David, what is different about this approach from your perspective, and what's so unique?
I think Kevin mentioned many of these things, but I think the big innovation here lies in the engagement for Medicaid, and ultimately the financing associated with this. Social determinants of health have become a mainstay of insurers and healthcare providers, right? Most organizations now have chief social determinant of health officers, or some other title that owns that role. And they understand that this is an imperative. Some of the larger and leading healthcare entities in the country have seeded this with large investments on housing, but that hasn't trickled down to everybody. And it's a long haul return, right? So you need to be able to willing to make an investment in housing, which it requires taking a perspective on how that impact will play out over years. And ultimately, there's a demonstrated commitment here from the state Medicaid office and buy-in from the state Medicaid office, as well as from key partners around how this investment in community housing and integrated services can then feed into a better downstream outcomes. I think the question around data is really compelling here, right? I think the Pearl also, as it moves towards launch, is in the process of developing a model to be able to share data and be able to tell that story on data and outcomes, which is a really important piece here. How do you ultimately create a narrative and a story of success requires that buy-in from that side. So there's been this challenge historically, right, where housing has been trying to prove its value as a healthcare, as a driver of improved healthcare without the healthcare data, right? And so, it's been a slow process to be able to overcome that challenge. And now with the buy-in and support from direct insurers and direct payers, there is this opportunity to be able to think about how you can tell that comprehensive story from somebody who comes in, right? How does it change things such as utilization on skilled nursing facilities and hospital visits and emergency room visits and increasing primary care access and better outcomes on diabetes measures and you name it. And so that story becomes really innovative, right? Just pure data in and of itself is not the innovation, but it's the ability to be able to tell that comprehensive story. And then at the end, to be able to say that there is a direct improvement in total outcomes and total cost of care.
Yeah, thank you for that. I want to go back to the community-based healthcare and Primus. Senator Horn brought up Dr. Aaron Shirley's vision and how this is an important example, an important model for community-based healthcare. Can you talk about the importance of community engagement, community support, and community-based healthcare in terms of how that's innovative through this project?
I'd be happy to. Dr. Aaron Shirley was a physician. He was, I guess, originally started out as a family practitioner and lived in a rural community over near the Mississippi River. And he often made house calls. And making house calls, you become a part of the community that you're serving. And as a part of that, sometimes he told the story that he didn't get fees for his services, and a lot of his clients had fishing holes, and they would let him fish, and so he would catch fish, take it home for dinner, and tell his family, "This is what I got for taking care of the patients today." So he was very instrumental in understanding who his patients were, what their needs were, and he saw the need for improved housing way back in the 50s and 60s when he was doing house calls, because he would get there and this kid's having asthma trouble and going in and out of the emergency room, and everybody thinks that the kid's not complying with the orders that the doctor gave. The kids finally find out the house loaded with lead or asbestos or something that's causing this, triggering these instances. And so you have to be able to communicate with the folks you're talking to. So in his mind, he had to figure out a better way to do that, or a more efficient way to do that, because he was actually involved in a lot of things by the time he got to the Jackson Medical Mall, and he didn't have time to be involved in making house calls anymore. So he paired up with a gentleman by the name of Dr. Shahbazi. Dr. Shahbazi is an Iranian, and he was very versed at how the Iranian healthcare system worked. And so he encouraged Dr. Shirley to go to Iran and just to look at the system there and see if there were some things that they could bring back to America to use. And I can tell you the challenges that Dr. Shirley and Dr. Shabaza had just getting that first trip out of the way, because our country didn't even have diplomatic relations with Iran. So they had to really work at getting the ability to be able to go over there. So they went and spent several days and went back and made several other trips, but they came back with a whole new concept, and it's called the community health worker concept, the health house and the community health worker concept. And what happens is you create a facility that's very central to a community, and it has the culture of that community, and you find a person and you train that person to be a community health worker, and that person becomes the operator of that health house. And so folks can actually leave their homes and go to the health house, use a computer to check their medications, check their diagnosis, check on their healthcare conditions, be able to talk to their physicians or their provider, and to get a better understanding of what's really going on with their care, and have a communication link directly with their provider. And so it sounds very simplistic, but it was very useful in being able to decrease the cost in some of the healthcare that's being provided to the folks in these rural communities. And so he and Dr. Shabazi did a pilot project that was very successful, and actually worked some with United Healthcare on that project. At the end of the day, it was using a person who lived in the community, understood the cost of that community, representing those patients in those physicians' offices, in the hospitals, and they found that the compliance with those patients using their prescriptions and their doctor's orders tremendously increased. And number two, the cost of providing healthcare for those clients decreased tremendously. So it was very successful, and it all boils down to making sure that the folks that are providing the care have a great understanding and a communication process with the folks who are receiving the care, and the outcomes actually changed at that point.
And we should mention that Jackson Hines Comprehensive Health Center, who will be the on-site healthcare provider at the Pearl, will have a community health worker that is there on site, focused on the residents. It'll be primarily seniors living in the 76 housing units there. So it's extremely exciting to have a community health worker really based on this model that you're talking about, Primus, to help demonstrate, improving health outcomes and really providing that community-based care. I'd love to hear from you all what you feel like the challenges are. I mean, that partnerships are so important, but what would you say are the key obstacles that we've had to work to overcome? Anyone who wants to pipe in here?
Yeah, I can add in something here, and I just want to build off of the last point on the work of Dr. Shirley and Dr. Shabazi. That my first connection to Kevin was actually through the New York Times article that talked about their work in the Mississippi Delta and in Jackson, and it was through that, and I heard about what they were doing and saw what they were doing and really wanted to learn more about it. In addition to the FQHC on site, right, the care structure of delivery within the Pearl is predicated on the model that we're talking about there, this community health worker model, specific to kind of how the CHW, community health worker, interacts with the residents, and how it had found to be massively successful in its ability to move the needle with residents during its initial pilots. It's important to call out the community health worker program that they implemented reduced readmission rates into rehospitalization rates by 20 points, right? And so relatively unheard of in terms of its success using kind of a community-oriented approach. So again, back to the innovation, it's the ability to think about a community-oriented model that's been built and developed in Jackson to facilitate the backbone of this integrated health and housing model. And I just want to add to answer your question, right? What are challenges here? I think the challenges here are creating scalability and stickiness with the insurers and building this into an integrated healthcare model, right? Ultimately, what gets really exciting is the ability to be able to show those downstream outcomes, right? To be able to show that you can overcome some of the challenges through integrated housing with healthcare services on site. And by doing so and creating that, you can create a virtuous cycle where it actually pays itself back, right? You're reducing hospitalizations, you're reducing high cost events, and better prevention means more dollars up front to service this and creating that sustainable model. Right now, it's around launch and implementation, but ultimately, and this is not as much of a challenge as it is an unknown, to be able to show that, right, and demonstrate that outcome becomes really a big opportunity and in something that is, you know, relatively new and novel. And then on top of it, being able to use that to potentially think about policy, right? And, you know, there's been great buy-in from the state in Mississippi, of course, you know, Senator Horn's here and has been a tremendous advocate for this to the state Medicaid office, and thinking about, you know, how does the Medicaid office then embed the learnings of this into something that is scalable across all communities in Mississippi, because this is not unique to just Jackson, right? And the population we're talking about there.
Well, Senator Horn, on that note, yeah, let's turn it to you to talk about scalability as well as obstacles. I mean, people may be sitting here thinking, well, why is it taking you guys so long to put together this this initiative and this project? But can you shed some light on the obstacles and our approach to overcoming those?
I think you have to be aware of the compartmentalization of things. Everybody's in their own silo. You know, health doesn't talk to mental health. It doesn't talk to health. Housing doesn't talk to. I'm not sure I said it right, but you compartmentalize. The housing folks don't generally talk to the healthcare folks, whether it's mental health or whether it's general health. And so you've got, if you're talking about innovation, you have to bring the right partners to the table. You know, that's critical. You got to bring folks who already have a great track record of accomplishment. Their reputation precedes them. You got to understand that again, bureaucrats, like most people in general, are risk averse. So they're not going to stick their necks out if they think that there's a chance it's going to get chopped off. So you've got to challenge these entities to voluntarily embrace innovation. And that's easier said than done. Nobody wants to be the first in. So you got to pick your partners carefully to and then get that big hit. If you get the big hit on the front end, it tends to run downhill from there. But having that team who's coming to the table, who has legitimacy. Everybody can have a great idea, but it doesn't mean you can get to the finish line. You know, another challenge was to me, one of the most groundbreaking things about this is not only the combining of healthcare on premises of where somebody lives, but it's also the data collection. You know, there's a trust factor there in terms of well, what are you going to do with this data? Who's going to collect it? How is it going to be processed? And so you've got to overcome that. Certainly the financing piece is a real challenge, especially if you're talking about innovation. And the importance of creative financing in this project or projects like it can be done. I would urge someone had a question about, well, where can we get sources of financing now? We're in the middle of a pandemic and there's a lot of money flowing. The American Rescue Plan has gobs of money out there right now, but how do you access it? And every state is getting, I'd say probably about $1 billion. Mississippi is getting 1.8 billion in this American Rescue Plan Act iteration right now. A project like this would be a great candidate for funding from a program like that. But you got to be able to get to the governor or get to the lieutenant governor or get to the speaker to press your case. because they're going to be the ones making those calls in general. It is a it's a process that is like birthing a baby. There are all kinds of things you got to look out for, you got to prepare for, you have to anticipate. And at the end of the day, hopefully you have a beautiful, healthy baby who's delivered. But you've got to just watch all those pieces along the way of that delivery. And I think you guys have done a great job with that. I can't say enough about GCHP and the work that it's done to lead this effort and to bring all the right pieces together.
Kevin, anything you can add about obstacles and lessons learned here, with an eye towards replicability and how we can replicate it in our region and across the country about what we're doing. I should mention, I don't know that we said that the Pearl is still in the pre-development phase. We expect to get under construction by the end of the year. So all this work we've been talking about, we're almost there in terms of being able to get the construction started. We still have more to learn, but Kevin, what do you feel like are some of our early lessons learned and obstacles we've been able to overcome?
Sure, and I think Senator Horn mentioning compartmentalization is critical in understanding or what we've learned in working with MCOs and seeking financing. I know that there's a lot of folks that have gone down that path. And one of the things I saw a couple, I'm just sort of looking at the questions in the chat, and some folks have asked about, well, what kind of data do we need to convince the MCOs, or how are you, how do you get those conversations started? And one of the things that we found is within, there's a realization that healthcare MCOs are massive companies. United Healthcare and Aetna are in the top 8 of largest companies by revenue in the country, with Apple and Berkshire Hathaway and all the big ones. And so what we've learned is that, getting your foot in the door with someone who's on the social determinants of health side with a healthcare payer and maybe really excited about your project, and you get a lot of great feedback, you get really excited. Ultimately, that project or that investment has to go through someone in Treasury Department who is comparing your investment against the returns of what else they're going to do with pretty massive amounts of capital. And so I think understanding that motivation is critical because you have to be able to make the case for that person at the Treasury Department and also understand their motivation. So I think we had mentioned it before that the Medicaid state contracts are a lever, and for us, there's kind of 3 main healthcare organizations, insurance companies that we've been working with. I don't think it's a coincidence that our initial conversations with Traction happened around state contract competition time. And so that's an important lever to be able to kind of get the door open. And that may, somebody from Treasury may have gotten a directive that we need to get a state contract in XYZ state. And so despite the fact that this doesn't compare well against other investment now, with the data that you have available, we're going to make one. And so that's understanding that motivation and using a state contract as a lever is important. On the flip side, one of the frustrations we've had is that one of those 3 health insurance companies that we've worked with 5 weeks before closing pulled their investment without a lot of explanation, and we have some sort of internal understanding or thoughts around where that came from. But the reality is that a lot of MCOs are figuring this out too. And so there may have been a directive from outside of the folks that we've been dealing with. We don't really know what happened, but it's been a frustration to understand that even within the MCOs, there are different pieces that you have to convince to be able to make these things scalable. And I think the scalability, what we've learned, it comes from finding the right people at an MCO who can make that change within an MCO. We've had conversations with folks at MCOs who have even said that's great. I think I can pull that team together, but it's something that is going to take additional effort for that person. And some of the early investments that MCO made and projects became one-offs because it was so challenging for a nonprofit organization or a housing organization to talk to all the right people and get all the right approvals and to make that investment happen. And that's not something that's scalable and can happen again. What we're trying to make the effort and trying to remind the folks that we're working with at MCOs is that we want to make this a scalable and repeatable thing where it doesn't have to go up to somebody really high within a large corporation to say yes to, but that there's a framework by which this sort of investment can happen. One of the MCOs that we're working with has changed their investment policy at a corporate level, and that had to go up to one of the largest corporations in the United States to change their investment policy to allow them to do more of this type of work. That I'd love to say that we can take credit for that, but we were one of many organizations working with this MCO, and it took somebody within that organization to make that happen. Several people there, and so the challenge is the frustration that it takes in continuing to reach out to people and talk to people and have conversations and figure out where those motivations are and figure out the right person. But the positive is that if you can find that person, you can try to make change within the organization, but to expect it to happen overnight is just not going to happen because there's a lot of motivations and they're very large organizations.
Yeah, Kevin, and I'd like to add that you better have a plan B. Because we were in the middle of the summer thinking that we had gotten to the financial finish line, and then guess what? The bottom's fallen out because labor costs and the cost of materials has gone up, because we're largely because of the pandemic, and then you got to drop back and pivot and go back to the drawing boards as far as finding additional resources. So I think understanding that here's our goal, and this is what it's going to take to fund this, and then because of issues beyond your control, you find that oh man, we got to go back out there and hunt for money, and so I think flexibility and being able to be nimble like that is a very important feature.
Absolutely, and this group has all been key to the persistence that that you're talking about here in terms of pushing forward, continuing to engage more partners, and that's really what what we've looked to do as one obstacle comes up. Look to find a new or different type of partnership to overcome that hurdle. Primus, from your perspective, what do you see as what the benefit and what will be of seeing this project to fruition? You've been as a part of this vision from the very beginning. So what do you see in terms of what success is going to look like and what's next in terms of replicability, whether it's policy change or ability to accomplish other projects like this in the area where you work?
Man, I can tell you the folks at the Pearl, the members of the church and that community are looking forward to being complete, because success begets success. And we have this whole corridor you talked about a little while ago, that Highway 80 corridor, that had the largest shopping mall in the state of Mississippi on it at one point, the Metro Center, and that thing closed down and everything around it started to die. So that mall was the anchor. And now that all communities are looking for a new anchor to get things started again, to get development jump started again. So this project will be that anchor for this community. And not only will we provide homes for 76 residents, seniors, but it will spur new development all around it, other housing opportunities. Developers will come there, start to see this, and it'll start to become a catalyst to redevelop that whole community. And right now, developers are staying away from it because nothing is happening there. So, but once this is up and running, this beautiful building that's going to be there with all the activity around it will spur lots of new activity in that community, and the sense of pride and community ownership will come back, and the folks will be bragging about it, talking about it all over the place, and it will help get the hope back to the folks who lost hope and don't trust anybody and think their community will always be disinvested in, and so that will start to return some sense of pride and hope to that community. It won't happen overnight. It'll be a process that will happen. And once it's all packaged, it will be scalable. You can take that same deal and another church in town will take a project, because the churches all over Jackson are buying property with the idea that they're going to do something to improve the community around it. And so for me, I'm just excited about the opportunity for that anchor to jumpstart the redevelopment and the repositioning of community pride and hope for those folks who live and work in their community.
Absolutely. Thank you for that. I think that's what GCHP is really all about, is working to be a stimulus for other investment and other development. So we are very proud to be a part of this, a part of moving this vision forward. We want to leave time for some questions from our viewers, but I just want to make sure that we, have made the key points that you all think are critical here, around innovation, replicability. So just want to take a moment for closing comments to really wrap us up here before we jump into our viewers' questions.
I just want to make, just go on the record to say my hat's off to Gulf Coast Housing Partnership for coming into this project, not knowing anything, not knowing anybody in that development. And they didn't come with the idea that they were going to save the community from itself. They came with the idea to be a partner. So I've appreciated that. And most times we don't know who's even in charge, because whoever needs to take the lead today takes the lead. It could be the community, it could be Gulf Coast, it could be a senator, it could be anybody taking the lead. But everybody's been great to work with. So my hat's off to you all for understanding that communities have their own culture, and you have to work within that culture to get things done. So y'all are doing an outstanding job of developing that trust with that community. So thank you very much.
Yeah, I'll just echo that. I think GCHP is just a remarkable organization, and I don't know about housing organizations that are nonprofit developers or for-profit developers, for that matter, who have more of an interest in building resilience and equity in the communities they serve. And ultimately, that's what we want in every community, it to be resilient and have equity, so that everybody who's in that community has an equal shot at the pursuit of life, health, and happiness. And in Mississippi, we're the poster child for what ails America. And there's a need for this project in the Mississippi Delta, more than one. But there are needs for projects like this all over America, because you have communities that have been marginalized, and healthcare access is one of the ways they've been marginalized. Housing access is one of the ways they've been marginalized. So my hope for this project is that it will inspire and instill in others the idea that they can do it too.
Absolutely. Any other closing comments before we turn it over to our viewers for questions?
I'd like to, once again, thank, we appreciate the appreciation for Gulf Coast Housing Partnership, but it makes our job a lot easier when we come into a situation that already has a lot of pieces in place, and we can be another piece there. And so the important part of that partnership has been that we focused on what we were good at and continued to do so, while other partners focused on what they were good at. And we worked together to do that. In terms of just closing remarks on working with MCOs and trying to direct more funding toward affordable housing, we've had some success clearly in trying to make these pilot projects happen, but there's a long way to go. And as an affordable housing community, we need to continue to work together to prove concept. And so the important part there, I think, is that the scalability will come from mutually beneficial transactions for both the MCOs and for the affordable housing developer and partners. And so coming to understand that, you know, we won't be able to get a giant grant maybe, but we could get low cost financing to build one more piece. And what does that mean to make it quantifiably beneficial for an MCO? Might not mean that, okay, there might be these really expensive Medicaid patients where there's a couple dozen that cost $100,000 or several $100,000 a year in a city. If they all live at that one development, sure, you're going to have enough cost savings to justify the investment. But we need to understand broadly what type of savings that healthcare company might have, and how that matches up with the debt or higher cost tax credit equity that they can provide. So there's a long way to go. We all need to work together on this, and that includes advocacy at a state level to encourage contracts, Medicaid contracts, to be awarded to MCOs who have an innovative approach to housing.
Well, Christy, I think we have had a great time having this discussion today, and we'll turn it over to you to facilitate any question and answer that we can follow up on.
Great. Thank you, Mary Elizabeth, and thanks so much to all of our panelists today, Senator Horn and Kevin and Mr. Wheeler and David. It definitely has been a great conversation, and I'm sure I speak for many when I say how excited I am to follow the progress and success of Gulf Coast Housing Partnership as you get these 2 pilot projects out of the ground related to the health and housing innovation. And we certainly would all love to be able to access new forms of capital to be able to increase the housing supply, but also access to healthcare across the country. So thanks so much. We had several questions come in. I'm going to do a little bit of combining of some of the questions to try to get to as many as possible. And I'll start with, there was a couple questions asking about supporting the services, the resident services at these developments. Is there any part of this model or structure that includes a health care payer investment in resident services or to support a community health worker?
At this point, for our 2 pilot projects, that isn't a part of the MCO investment. We've been focusing on MCOs helping with the capital stack, and what our hope is that once we have a quantifiable financial impact for the services and housing and the whole package that we can provide, that there are other ways that an MCO can help. There's essentially a quantifiable amount of discount to market that an MCO is going to provide with its capital. Maybe that means that they're providing lower cost debt. Maybe that means that they're providing higher cost equity. Maybe that means that they're providing services, supporting services to the project. But I think that's the piece we need to get to, is what is that number really, and understanding or range of numbers. For the pilot projects that we're working on, specifically for the Jackson project, the on-site FQHC, as Mary Elizabeth mentioned, is going to employ the community health worker. Part of the motivation that they have for that is that the Medicaid organizations assign primary care providers by algorithms that will make, because that FQHC is on site, will make it more likely that FQHC becomes the primary care provider for that resident. Those algorithms are in part based on geography, in part based on if they visited before. This is for folks who have not selected their own provider. So that's part of the motivation. But what we've addressed in this pilot project is that we've got another payer essentially for those services. But the mutability of that will be that maybe in another project where the capital stack is complete, but there is a need for that services, then the subsidy from the MCO comes in a different form.
Yeah, and I would say that Medicaid drives a lot of this. And if community health workers are not an allowable expense under the state Medicaid program where you exist, then you probably need to talk to the Division of Medicaid and members of the legislature, because the technical amendments bill is what drives what's in Medicaid and what is allowable. That is determined by the state legislature. And so if there's not an allowability for reimbursement of community health workers, you're not going to see a whole lot of community health workers. So if you would work to get your Division of Medicaid operations to include community health workers legislatively authorized, then you'll see more of that.
Great. Thank you both. So to add on to some of the conversation that you all had about data, there were a lot of questions, as a couple of you mentioned. How are you tracking resident outcomes, if there's a succinct way to summarize that? And then any advice on how to use qualitative data in addition to the quantitative data that you're collecting?
I'll let David add
Yeah,
on.
sure.
But essentially, the two ways that we have seen or expect to collect data is from individuals, like actual individuals living in a development, and we will not see, from the payer perspective, we might not see that Jane Doe had XYZ reduction in cost, but we will see that residents at a facility have had XYZ reduction in cost. And so it would be great if we can say that these, 15 people had this kind of savings. But we also realize that we may not have folks that live in a certain facility for a long enough period of time. And so the qualitative and comparative data will also be important to say here, Jane Doe is within XYZ demographic, and a person in Jane Doe's situation who otherwise doesn't have stable housing and doesn't live at the Pearl would have this kind of expenditure annually, and and Jane Doe has this, which is less. And so that's something that Medicaid providers have in terms of data. What we're working on is the provision of that and getting their attention on certain levels to be able to get that. So we're going through that kind of MOU process now, and I can let David add more technical to that, but that's kind of that's been what we've come to in terms of an approach.
Yeah, I mean, I think that it's a comprehensive process that we're designing, but I think, I'd boil it down, to a handful of areas, right? One is, what does the experience look like in terms of going through the Pearl? The second is understanding what are the direct patient outcomes, right? So those are direct measures that Kevin alluded to, right? Things like HbA1c and other diabetes measures, other things that actually tell a story on an individual's health. And then and then there is a kind of a layer around utilization improvements, right? What have they done? What have they not done? How has things changed? And then, of course, the most compelling data, which is what we've been talking about, is direct claims data. So being able to tell a story on what actually changed. When I say claims data, this refers to, for those that are unfamiliar, right, the direct data that insurers have on billed services that have been reimbursed. And that information really tells a story on what has happened over the course of the last 6 months or the last year. To go to the other half of that question, right, on what about qualitative data, that's important too, right? The story of how individuals experience services, respond to care, is really important. I think payers are working at a disadvantage right now too. So they are not working off of an upper hand with the quantitative data where they know what they know. Everybody's at a mutual disadvantage in terms of understanding that there needs to be better investigation. So if an organization has good qualitative data but weak quantitative data, I think this is where there's an opportunity to be able to thread that needle with partners to be able to tell that story. And cumulatively think about how this improves outcomes. I think I would say, in working with payers, we're talking about Louisiana, in Mississippi, but across the country, they're eager to know how interventions improve outcomes. As much as we talk about how hard it is to engage insurers and Medicaid and the healthcare industry, it is as equally hard for Medicaid and insurers to engage with housing, with developers, and with community-based organizations. And so there is a communication breakdown that happens on both sides. So for organizations that look at the black box on the other side, kind of reflect on that perspective and think about how you can create a partnership for change. And I think, you know, coming at it from an optimistic perspective is well warranted.
Great, thank you. So some questions came in specific to the Pearl and specific to Gulf Coast. So wondering if there's going to be some sort of a case study or something that documents what this process has looked like, that can be shared broadly for others to replicate, which is the whole point of this work. And within that, will you be sharing the capital stack of these many partners and investors to bring this development to life?
I can start with the capital stack and then Kevin pass it to you for studies. Yes, that's a great question. We referenced how many financing sources we have. So we have secured financing for the housing and the clinic separately to help facilitate a range, the most diverse type of financing we can. We have 9% housing tax credits, home funds through the state of Mississippi, home funds through the city of Jackson, housing trust funds through the state of Mississippi, financing through our partnership with United Healthcare. We have a Federal Home Loan Bank of Dallas Award, Federal Home Loan Bank of Atlanta Award, historic tax credits, both federal and state historic tax credits, and federal and state new markets tax credits. As well as, forgot one more, which we have an award from the Department of Health and Human Services Community and Economic Development Program that'll directly support the clinic portion. So it is a pretty tall capital stack. And, you know, when we talked about the time to put together to get to here and the partnerships required, we did not mention sufficiently the financing partners that are making this possible. And so those are very important to make this happen.
That's a lot of spreadsheets.
And I know what many of you may be saying at home now. Well, great that you can do all this with 14 different financing sources or whatever it is. And I'm sorry for you, Mary Elizabeth, to have to deal with all those. The critical piece for these pilot programs, the one in Jackson and the one in New Orleans, is that they are pilots that will allow us to leverage this type of investment from healthcare payers on a broader scale, and hopefully with projects that need to be much less complex to make them a reality. So the important part is that there's been a tremendous amount of work to make these two pilot projects become reality. If they're the only two projects that we do and the only investments we get from MCOs, it certainly wouldn't be a bad thing, but that's not the intent, because it's been a lot of work to put it together. And so the scalability is a critical component of that. And in terms of sharing, you know, a study, we're certainly that's critical to. We can't scale this unless we can demonstrate how it happened and demonstrate the impact that it had. And so certainly that's one of the things that we're going to be working with David on in terms of evaluating health impact for both transactions and really having a playbook for here are the core components of what made this successful and here's the impact that it had. And once we're there, we will share it broadly because that's the point. We want to, we do not want a small slice of the pie of MCO funding to go to GCHP projects. We want to make the pie much bigger and have a smaller slice of it, you know. Yeah. So to be determined, because we're still not there yet, but we will absolutely have a shareable study
Yes.
at the conclusion of this.
And I would say to our audience members, definitely to check into housingbreakthrough.org, where we follow the progress and success of Gulf Coast Housing Partnership and our other challenge winners. So that is our time for today. So again, thank you to all who joined us today. Thank you to our esteemed panelists. And I encourage you to stay informed about the progress of this work and other challenge winners You can subscribe for updates or just check back on the website. There's going to be a lot of exciting updates coming through now that our challenge winners are, a year into their innovations. There's going to be a lot of incredible storytelling and successes to celebrate there. So with that, again, want to say thank you to all. Please note if you would like to connect with any of these groups, their websites are listed on the slide that you see. And with that, stay safe and be well, everyone. Goodbye.